thanks for inviting me here today. I'm very happy to talk about some of the orthopedic implications of hypophosphatasia. And really what I want to talk to you today about is, how HPP and bone deformities relate, how bone density and osteoporosis are related to HPP, because once you're treated for your HPP, yes, you've taken care of the HPP, but you haven't really cured yourself of aging or hormonal loss later on in life. So you do succumb to a competing disease called osteoporosis, and then I'm going to go over the orthopedic management of that. So just, going back in time again, there was mention about, when was, HPP first diagnosed. And if you go back past Dr. Rathbun's first diagnosis, 1940, there was a doctor known as H.B. Macy, who was an orthopedic surgery attending at the Mayo Clinic, and he described at that time a 36-year-old Norwegian descent male who had bilateral femur pseudofractures, also fractures of the scapula, tibia, and ulna. Delayed ambulation in childhood. He self-reported that at age around 3. It took him to walk. And then, he wore steel braces for most of his life, and he had, knock knees, genu valgum. And his brother also had pseudofractures. And he had presented with this, femur fracture, as I sort of diagrammed here, that had been plated. And interestingly, on the workup at the Mayo Clinic was an absence of serum alkaline phosphatase. He had normal calcium and phosphorus levels. He subsequently underwent the fracture fixation. The alkaline phosphatase normalized, but then afterwards it started to decline again. And they came up with, they really hadn't seen this before. The best diagnosis that they could come up with was OI, TARDA, basically, late presenting osteogenesis imperfecta. So right disease, wrong name, and then again, as mentioned before, Dr. Rathbun in Toronto diagnosed a patient with hypophosphatasia. This is the first description of a 3-week-old boy, no family history of disorders, lost weight. When you handled him, that precipitated crying, and then he had a soft head, as well as multiple seizures, and unfortunately died shortly thereafter. And from an orthopedic standpoint, it's interesting to see that, from the original article, you see this like super wide wrist, and that's classic for patients with, untreated osteomyelitic or ricket type states. And if you get an X-ray, you see the little pseudofractures that are in the forearm at the distal end towards this area here. And those pseudofractures can go on to become completed fractures, and they just fail to heal. And then again, marked decalcification of the skull. The skull, for the most part here, doesn't show any, calcification. The only certain smaller areas are actually calcified with normal mineralization here. And again, Dr. Rathbun had noted that, throughout this child's short life was, the alkaline phosphatase levels were nearly undetectable. And then post-mortem tissue diagnosis showed that the alkaline phosphatase in several organ systems, like, your small intestines and lung and kidney, as well as the bones, were all exceptionally low. And calcium content within the bone itself was also exceptionally low. So yeah, I mean, they analyzed this child's calcium content within the bone, and it was found to be markedly low as well. And then in addition, if you looked at the mineral content, and then going at the, that area of the widened wrist, if you actually looked at the growth plate, there's haphazard growth of the cartilage that makes up for the actual length of the bone. So normally these would be in nice straight columns. In this case, they are just kind of thrown in a mess. So, after this publication, it became known as Rathbun syndrome or Rathbun's hypophosphatasia. also known as phosphoethanolaminiuria, and then eventually became known as HOPS, which is just another name for hypophosphatasia, and eventually the current acronym of HPP, or hypophosphatasia. And why am I interested in this? My mentor and metabolic bone hero when I was a fellow at Mass General was Dr. Henry Mankin. And Dr. Mankin, interestingly, he was an orthopedic oncologist, but also had a very strong interest in metabolic bone diseases. And as a fellow and also as a resident, I had attended several of his talks on metabolic bone diseases. And one of the things that he discussed was hypophosphatasia. And at the time, this was like 2000, 2001. That he said, well, unfortunately for hypophosphatasia, there's no disease treatment. You can try to treat with high doses of phosphorus, you can try to treat with vitamin D, but that's not going to work. And unfortunately, there wasn't really anything else to offer these patients. So what he ultimately said for the orthopedic care of fractures and HPP, that these are crippling deformities and that it's difficult to treat them because the devices really aren't effective in maintaining good alignment because they frequently cut out. The bone is too soft to hold the hardware. And again, this is all prior to the discovery of HPP treatment. Some of Dr. Mankin's paradigms were, well, for any metabolic bone disease, address the metabolic bone disease disorder first before diving into surgery, because, again, your outcomes after surgery are going to be largely dependent upon how well that disease is treated and how well that bone is going to heal and how well that bone is going to hold up to hardware fixation. If, for instance, you had an acute fracture that came in, yes, you would fix the fracture and address the disease later. But if you had an elective case, you would try to treat the disease first. Once the advent of aspartate enzyme replacement therapy had come about, this basically allowed us to now treat these patients successfully, and hopefully will in the future not have to deal with orthopedic surgery fixation whatsoever. Because now you have a disease treatment that allows for deformity prevention. So if you treat early enough, hopefully you're not going to get the bowing and pseudo fractures. It'll prevent the deformity progression. And there's also the potential to heal impending pathologic fractures. Again, the pseudo fractures that originate from HPP can now start to mineralize and heal. And this is a multidisciplinary team effort. It's not just your orthopedist, it's not just your endocrinologist, it's a combination of a variety of people that helps you with managing this disease disorder. And so ultimately for HPP patients in orthopedic surgery, especially long bone surgery, the intramedullary nails or rods that we call are the preferred method of treatment. And I'll show you pictures of that in a second. Why? Because these are load-sharing devices. They allow the central positioning of the hardware to bear the best mechanical load. So the rods don't cut out so that the fracture doesn't happen at the ends of the plate or anything like that. Plate fixation is really not preferred, but sometimes it's the only option that you have when you are very far ends of the bone, such as like down by the knee or by the elbow. And osteotomies are basically cutting the bone so that you can straighten the bone so that you can allow to put a rod in, because the rods are straight, the bone is not. You may need to have the bone cut in order to allow fixation. And then you may also have to graft the bone, basically using allograft bone material, whether it's cadaveric bone, whether it's your own bone, or whether it's a bone substitute to allow for bone healing. So an example, this patient with HPP who developed a pseudo fracture and then eventually a completed fracture that had this varus deformity or turned in shape with anterior angulation. You see what it looks like in real life, and then subsequently the surgery to correct that. And Again, this is the metal rod or nail that's put into the bone, and this bone probably should have been what we call osteotomized to allow the rod to actually traverse the fracture in a better alignment, because there's still some misalignment down at the bottom there. Plate fixation, again, is really not advised in patients with hypophosphatasia. Why? Because you can fix the fracture that originally occurred down here, and that'll heal, but then all of a sudden you're chasing your tail with fracture occurring at either end of the plate. And again, this is prior to HPP treatment. If you're on HPP treatment with Strensiq, you're probably not going to have this happen to you. Plate fixation, again, can fail. So you can have hardware not only cut out, but you can also have it break. So in this case, this patient who had a blade plate put in, the fracture probably took some time to heal. The hardware failed, plate broke. The fracture actually eventually did heal. Unfortunately, this patient went on to fall and basically fractured below this hardware. So again, plates only treat part of the bone, they don't treat the entirety of the bone, and that's why rod fixation is preferred. About 10% of HPP patients, and again, this is the untreated population, will have a risk of subtrochanteric fracture. So again, you have patients that develop these stress fractures, subtrochanteric areas here, or let's say the total hip replacement, there's a fracture developing at the tip. Probably would want to go with, again, a long stem device for a total hip replacement if you're not under treatment with Strensiq. And for any other areas like this femoral neck fracture that was fixated, probably would have been better off with what we call a recon nail or reconstruction nail. And again, even despite putting a nail in, you can still continue the fracture in areas that aren't protected. So it really becomes sort of a chasing your tail aspect of things when you're not on treatment. And so fractures can end up healing poorly when they are untreated without Strensiq or some type of treatment. Deformity correction, for bowed extremities with HPP, that can be successful. You can basically, what we call, again, cut the bone or osteotomize the bone. In this case, pin fixation allows that bone to heal in a nice straight position, but then you have to worry about the other bones. And so, yes, the tibia is nice and straight, but now you have other bones that you're going after that continue to deform and then also require osteotomies. And again, with HPP treatment, hopefully this is going to be a thing of the past. There are other devices that we can use aside from rods to straighten out bones. This is what we call an external fixator, and basically we put pins across the bone, and through threaded armaments here that basically once we turn these, we can actually slowly correct, millimeter a day of correcting this angulated tibia bone that's been cut purposely to allow this bone to eventually kind of transition over into a more straight position. And again, all right, well, you've treated it, but then like a few years later, you could be back to square one again if the disease is not treated. So again, the idea here is to treat the disease so that it doesn't come back or doesn't become a constant problem in terms of angulation. Other HPP bone manifestations, scoliosis, curved spine with progression. I'll leave that for another talk. And then periarticular calcification, calcified joints, often getting diagnosed as quote unquote calcific tendinitis. I was just mentioning to one of the folks here that I had a gentleman that was seen by our shoulder upper extremity service and diagnosed with quote unquote calcific tendinitis, but they noted that the bone density was really kind of low in this patient and sent him to me for osteoporosis workup. And on the secondary osteoporosis workup, I noted that it's like, wow, his alkaline phosphatase is low. That's interesting. Repeated again, yes, it's still low. And then eventually he was diagnosed with HPP. So that calcific tendonitis in the shoulder was really a manifestation of his HPP. So again, treat the HPP first and address the orthopedic problem whenever you can. This is what periarticular calcifications occur. These can occur in multiple areas in the body. This one's around the elbow, here and here. But they can occur in the shoulder, they can occur in the hip, they can also occur in the spine. And as previously shown, with aspartase enzyme treatment, you can get significant remineralization, as noted early in the first talk, that you just get dramatic remineralization of the bone to allow normal function to happen. So, all right, so my, HPP is on treatment, am I really out of the woods? And as I mentioned earlier, one of the problems, the competing problems and the double whammy that was mentioned before, that yes, your HPP can be treated, but that doesn't stop you from aging, that doesn't stop you from hormonal, loss. And so one of the other problems I encounter because of my metabolic bone disease clinic that I manage patients with osteoporosis is patients with HPP who are postmenopausal. And what do you do with these patients and how do you treat them? Interestingly, in the osteoporosis literature for HPP, it's very sparse. I probably would say there's probably about 3, maybe 4 papers out there, relating to bone density measurements in patients with HPP. So one of the things that they found is that the spine can be artifactually elevated in terms of bone density, and really you probably shouldn't use the spine as a bone density measurement. You probably should look at the hips as a better, more accurate site of bone density measurement. And again, for the spine, just like I showed you in the shoulder, you got this calcific tendonitis. You have the same thing going on with the spine, with the vertebral discs, like what we call a dish-like phenomena or diffuse idiopathic skeletal hyperostosis phenomena. And what is osteoporosis? And this is my plug for osteoporosis, that osteoporosis comes from the Latin term holes in the bone, and it really means that you have a low bone mineral density combined with a structural deterioration that leads to bone weakness and an increased risk of fracture. And we see this every day in patients, this sort of bent over shape, what we call the dowager's hump. And the vertebral bodies that make up the spine that cause this problem have been crunched down. So they're kind of squashed down like a marshmallow over time, what we call codfish skeletal deformity. But if you take one of those and you add that to multiple other vertebral segments, you end up with this huge kyphosis in the spine, or this dowager's hump. And osteoporosis leads to fragility fractures. And what's a fragility fracture? Well, any fracture that occurs from a ground level fall. So, I mean, normally if you're 30 and younger, if you fall, you're just going to bruise or something like that. But if you're have osteoporosis and you fall and you fracture your wrist, and it's like, that probably shouldn't have happened. And I get a lot of patients that dismiss and say, like, well, anybody would have fractured the way I fell, but that's not really the case. That really is a subtle way for you to know that you now have osteoporosis. So, and then even lifting a box up from the floor, if you end up with a compression fracture in your spine, that's a fragility fracture. That shouldn't have happened. It's a fairly common disease, albeit poorly treated and not very well recognized. It's about 1.5 million fractures per year. And you may say it's like, well, yeah, I hear breast cancer all the time. I hear about stroke all the time. I hear about heart attacks all the time. But the combination, if you add up all the number of heart attacks, strokes, and breast cancer, the osteoporotic fractures in the United States per year trumps all that. Fascinatingly enough, but it's still not a disease that's really addressed. And why is this important? Well, if you're 50 and up and you have a hip fracture, well, there's a 1 in 4 chance that you could die after your hip fracture within a year's time. So it has significant morbidity and mortality. Permanent disability, about 30% unable to walk, and 40% unable to carry out a activity of daily living, in about 80%. So I always try to emphasize to my residents, my medical students, and my public population that, osteoporosis does cause death. It's a serious issue that doesn't get addressed and doesn't really get recognized as much as it should. What about the, other aspects? Heredity, is a risk factor, and mom and dad had it or your sister had it, you're more likely to have it. Postmenopausal women, for hormonal loss, you start losing bone at about 2 to 3% per year. Poor lifelong calcium intake. I mean, if you're just crummy on terms of like calcium intake, poor on dairy products, that can lead to a poor peak bone mass, and that can lead to earlier osteoporosis. And again, you reach peak bone mass at about age 30, and osteoporosis starts happening sooner than you think. After age 30, you start losing bone about 1.3% per year. When you go through menopause, it accelerates tenfold to about 2 to 3% per year for about 10 years, and then slows back down to about 0.1 to 0.3% per year. So it's something that you need to address sooner than you think. Other patients, you could have HPP, but you could also be on prednisone for whatever reason, or maybe anti-seizure medications, or you could be on an antidepressant as a selective serotonin reuptake inhibitor, or be on Lasix, furosemide, or you might have breast cancer and been on aromatase inhibitors like Arimidex, or you could be on proton pump inhibitors like omeprazole or pantoprazole. All that induces osteoporosis. Other, concurrent disease conditions like diabetes, kidney disease or kidney transplants, heart transplants, gastric stapling, anorexia, bulimia, celiac disease, neuromuscular disorders, all predisposed to osteoporosis. Even HPP has poor mineralization that predisposes you to osteoporosis. And how do you diagnose osteoporosis? Well, a DEXA scan is the gold standard out there, but as I mentioned before, one of the problems with DEXAs is that you have this artifactual elevation in bone density at the spine because you have this calcification along the spine vertebral discs. And that's, again, due to the excess accumulation of this inorganic phosphate that, leads to these periarticular calcifications. Interestingly, in one study, it showed that increase in spine bone density scores probably indicated that you had a more severe form of HPP as what they were correlating to the patient population. Where is a better place to measure, at least with the DEXA scan tool that we have at hand, is probably your hip, probably a more accurate measurement. So I probably should focus on the hip scores rather than the spine scores. So what component of a fracture is related to HPP versus osteoporosis when you're, let's say postmenopausal and you have HPP? Well, sometimes we really don't know. I mean, we have to investigate, your clinical history. How did the fracture happen? What does the x-ray look like? Is it just demineralized at that area? Probably an osteoporotic fracture. But if there was a pseudofracture there to begin with, then it was probably related to the HPP. We overall need a better tool for measuring bone densities in patients with HPP. We really don't have a good tool, but one that is experimental, and you can see these sometimes used in clinical trials, is what's called QCT, or quantitative CT. It's a lot of radiation. It's time consuming because you're taking these like 0.5 millimeter cuts or less of, through the bone. And as a result of that, it's time consuming, and it does expose you to a lot of radiation, but it gives you this phenomenal picture of what's going on the inside of the bone. You have this microarchitecture that's just amazing to see, and that tells you a lot about what we call the quality of the bone, whereas bone density DEXA scans are just telling you what the density of the bone is at. So hopefully in the future we'll have QCTs available for this type of disease and get a better measurement. Overall, what's your goals in osteoporosis care? Well, really the medication to stop further bone loss. Yes, you need the normal building blocks. You have to have normal calcium and vitamin D levels, and weight-bearing exercise to maintain normal bone metabolism. Bone loves to have force on it. It loves to have, it'll thicken as a result of exercise and muscle contractions. It's not a cure for osteoporosis, and neither is calcium or vitamin D a cure for osteoporosis. You really need a pharmaceutical agent to halt further bone loss. Safe osteoporosis treatments for patients in HPP. Well, there's only a few articles out there, and most of them are case reports. There is, evidence that bisphosphonates are bad for treatment in HPP. And so why? Because it basically makes the pseudofractures worse. There are case reports saying that denosumab treatment probably is not a good idea either. This is, an anti-rank ligand agent. And on the other hand, there's another drug that's in development called setrusumab, which is currently being pushed for patients with osteogenesis imperfecta, but there is a study looking at use in HPP that seems to improve the bone density without increasing the risk of generating pseudofractures. So setrusumab may be another option. There's a couple case reports of teriparatide or Forteo use being successful. There's no data that I could find on abaloparatide, Tymlos, or Evenity, Ramosumab as of yet. And figuring that, abaloparatide is in the same class of drug as teriparatide, probably okay to use Tymlos, just like Forteo is currently being used. And Evenity, I have no idea. That's something that we're going to have to investigate further. So again, just showing you what, the bad things from bisphosphonate can be used. This happens in patients without HPP that develop these sort of what we call atypical femur fractures or stress fractures in the bone. And this is simply like getting up out of a chair and making a turn and pivoting, and that torque on the bone is enough to fracture through the bone. And as you can see on the other side in this patient, they had a developing stress fracture on the other side. They do go on to heal, but again, most of these atypical femur fractures on the lateral femoral cortex, that seems to be the only place that they occur. On the other hand, HPP patients have these stress fractures occur on both medial and lateral cortices. So it's a little bit different in terms of the radiographic presentation, but similar end effect, a fracture. So again, why am I interested in this? Even if you have HPP and you're on treatment, you could still fracture because of age-related bone loss or menopausal-related bone loss. So again, death is a big concern. 1 in 4 patients dying over the age of 50 after a hip fracture, permanent disability of 30%, inability to ambulate independently, 40%, 60%, at least one ADL. Activities of daily living, like simply going out to your mailbox and getting the mail, or going out to the supermarket to get food, you're not able to accomplish. Vertebral fractures and any type of fragility fracture begets yet another fragility fracture. Spine fractures, 9-fold increase of yet another, fracture after an initial vertebral fracture. And many people may look at this and say, well, that's just a normal part of aging. It's like, all right, grandma, went that way, and I figured there's nothing that can be done. But we have great medications that will treat this, and we can stop this process. This is something that we have great drugs now for HPP. We have great medications out for osteoporosis. Unfortunately, both are incredibly undertreated or underrecognized in this country. And again, just recapping, the orthopedic tips. If you do have a pathologic fracture and you have HPP, we'd prefer putting a rod in over that of over that of a plate, because a plate fixation may not address the entire bone from fracturing later on. And you may need the bone to be cut to straighten it, or you may need bone grafting to get the bone to heal. Again, hopefully with HPP treatment that, this will be a thing of the past. And as Dr. Mankin said, my mentor, address the metabolic bone disease order first whenever possible. The aspartase enzyme replacement therapy has this great opportunity to prevent deformities from happening in the first place and then prevent progression of any deformities that are currently existent. And then also allow for, these pseudo fractures to heal. And it takes a team effort. Again, probably stick with, teriparatide or setrusumab once it comes out. Don't use bisphosphonates. And that's what I had for you in terms of for orthopedic implications of HPP. So thank you.